Hello everybody, hope you all are fine. Today we are going to discuss the part second of the main thoracic vessels. So at the end of this session, the participant should be able to describe thoracic aorta, its parts, its origin, course, termination and branches of each part. As regards the clinical relevance, the participant should be well aware of the aortic knuckle, coarctation of aorta, patent ductus arteriosus, and aortic arch aneurysm. Now we start with the description of the aorta. Aorta is the main arterial trunk which receives oxygenated blood from the left ventricle and distributes it to all parts of the body. It extends from aortic valve of left ventricle, which is also named as aortic root, to its bifurcation at lumbar fourth vertebral level into common iliac arteries. It is divided for descriptive purposes into two parts, thoracic and abdominal, by a long line drawn at lower border of T12 vertebra. Thoracic part is again divided into three parts by a line drawn from sternal angle to the lower border of fourth vertebrae, and these parts are ascending aorta, arch of aorta, and descending aorta. First, the ascending aorta. It is about 4 to 5 centimeter long, starts from the left ventricle and is enclosed in pericardium. At its start, it has got three dilatations which are named as aortic sinuses. These aortic sinuses are anterior, left posterior, and right posterior. It begins behind the left half of the sternum at the level of lower border of third costal cartilage and proceeds upward, forward, and rightward, and ultimately terminates as continuation of arch of aorta at sternal end of the upper border of second costal cartilage. It has got two branches, right coronary artery, which originates from the anterior aortic sinus, and left coronary artery, which originate from the left posterior aortic sinus. Second part of thoracic aorta is the arch of aorta, which is continuation of the ascending aorta. It is located in the superior mediastinum behind the lower half of the manubrium sterni. Arch of aorta begins behind upper border of second right sternochondral joint at the lower border of body of fourth thoracic vertebra. Arch runs upward, backward, and to left across left side of the bifurcation of trachea and passes downwards behind left bronchus and on the left side of fourth thoracic vertebra. Hence, it arches over the root of left lung. Arch terminates at the lower border of body of fourth thoracic vertebra as the ascending aorta. Point to be noted is, and we can appreciate by analyzing the upper and lower diagrams on the right side of the slide. That is, beginning and end of the arch of aorta is at the same level, but it begins anteriorly and ends posteriorly. And by its passage, it has got two concavities. one inferior and the other one on the right side. This can be confirmed in the diagrams. As regard the branches, the first branch of the arch of aorta is brachiocephalic artery, which divides into right common carotid and right subclavian. Second one is left common carotid artery, and the third one as the left subclavian artery. Third part of the thoracic aorta, that is descending thoracic aorta, is continuation of arch of aorta and itself continues as the abdominal aorta. It is located in the posterior mediastinum and begins on left side of the lower border of the body of fourth thoracic vertebra. It descends in the posterior part of thoracic cavity with an inclination to the right and also the front. It ends at lower border of 12th thoracic vertebra. Has got a number of branches. Number 1, nine pairs of posterior intercostal arteries, a pair of subcostal arteries, 2 left bronchial arteries. Right bronchial artery originate from the right posterior intercostal artery. Fourth, esophageal branches for the middle one-third of the esophagus. 5. Pericardial branches to the posterior surface of pericardium. 6. Mediastinal branches for the areolar tissue and to the lymph nodes in the posterior mediastinum. And finally, the superior phrenic arteries for the posterior part of superior surface of diaphragm. The branches of the superior phrenic arteries anastomose with those of the musculophrenic and pericardiophrenec arteries. Now we come on to the clinical anatomy. First, the aortic knuckle. In postero-anterior view of the radiograph of the chest, arch of aorta projects beyond left margin of the mediastinal shadow. This becomes more prominent in old age. Second is coarctation of aorta. It is localized narrowing of the aorta opposite to or just beyond the attachment of the ductus arteriosus. Because of this blockade, extensive collateral circulation develops between branches of the subclavian arteries and descending aorta. These anastomoses between anterior and posterior intercostal arteries produce a characteristic depressions, which are named as notching of the ribs. Third component in the clinical anatomy is ductus arteriosus, ligamentum arteriosum, and patent ductus arteriosus. During fetal life, the ductus arteriosus is a short, wide channel which connects beginning of left pulmonary artery with arch of aorta, immediately distal to the origin of left subclavian artery. This ductus conducts most of the blood from right ventricle into the aorta, hence short circuits the lung circulation, which is not yet fully established. After birth, as the lung circulation is established, the ductus is closed functionally within a week or anatomically within about 8 weeks. Its remnants are present as a fibrous band, which is named as ligamentum arteriosum. Left recurrent laryngeal nerve curves below and behind aortic arch at the level of ligamentum arteriosum. In some of the cases, the ductus may persist. Then it is named as patent ductus arteriosus, which is a serious clinical problem. and is treated surgically. Fourth component in the clinical anatomy is aortic arch aneurysm, which is a localized dilatation of the uh, aorta, which may press upon the left recurrent laryngeal nerve because of the proximity of the nerve to it. If it happens, it may lead to paralysis of the left vocal cord and the hoarseness. If the aneurysm is a large one, it may press upon the surrounding structures and may cause mediastinal syndrome, causing obstruction of the superior vena cava, which manifest in the shape of puffiness of the upper part of the body. Similarly, other structures in the area, if pressed upon, give rise to dyspnea, dysphagia, and dysphonia, etc. Comments and suggestions will be welcomed. Thank you for listening and watching.